Okay, I think it's time to start. I would like to welcome you all to this joint webinar between the Global and Humanitarian Committee and the Pediatric section. And it will be a fantastic, interesting subject with pediatric hydrocephalus in low and middle-income countries. It's a huge problem. We have a fantastic set of lecturers. And my name is Magnus Tisell, and I'm from Göteborg, Sweden. I'm chairman in the Global and Humanitarian Committee. I'm a co-chair.
Hi, my name is Jehuda Soleman. I'm from the pediatric section of the EANS and working in Basel, Switzerland. Also very excited for this webinar.
Yeah. So, and we just tell you right away that if you have a question, we will have a discussion in the end after all the 4 lectures. And we like to that you should use the Q&A function, not the chat function. So try to do that. And then I would like to introduce the first panelist, the lecturer, John Jabang, a good friend to both me and Jehuda. I know him since many years. He was for a long time the only single neurosurgeon in Gambia. Now things have changed, and he has a long experience of dealing with pediatric hydrocephalus, of course. And John, as you're not in Gambia now, but your heart is always in Gambia. So please go ahead. We can start the presentation.
All right. Okay. Sorry, let me just share my screen and
yeah, it looks good.
okay. Why is it that it was going before? Okay, so thank you so very much. Like it is said, I'm John Jabang. I'm a neurosurgeon from the Gambia, and it's a pleasure to be here. I want to thank the Humanitarian Committee and also the EANS for inviting me to come and just share our experience from the Gambia with you. So my topic would be on treatment of pediatric hydrocephalus in the Gambia, but I'm going to look at it really from the question that was asked, an experience from an LMIC country and how a contribution can come from abroad to help. We always stand on giants, in whatsoever we do in life. And so I am grateful to the people that have brought in so much knowledge to me, and especially the Department of Pediatric Neurosurgery in Tel Aviv, led by Shlomi at the time. And there I was with a very, very handsome man by the name Jehuda Soleman, who is today a co-chair in this meeting. It's a pleasure to meet him and spending 1 year with him, and also Daniel Kozarev. For those of you who do not know the Gambia much, we are the smallest country in mainland Africa, with a population of now about 2.4 million. We are surrounded by Senegal on the north side, south side, east side, and only on the Atlantic, on the west side, that we have the Atlantic. So it's a small country. And like Magnus said, that I started neurosurgery in Senegal, in the Gambia, about 10 years ago, when I was the only neurosurgeon for 8 years. And now we are having almost about 3 to 4 neurosurgeons currently working in the country. Of course, as a background, we all know that hydrocephalus is basically ventricular dilatation that is occasioned by hemodynamic disorder. We know that the investigations obviously would mean that one would either use a transfrontal ultrasound for us in low middle income countries, CT scan also for us, and MRI. And of course, this talks about cost implications and management implications. We know the clinical features of hydrocephalus. We know most of them are due to signs of raising intracranial pressure, and for an infant whose sutures are not closed, it could be progressive macrocrania and other signs we all know. We obviously know also that the treatment is shunts that has been used for a long time, endoscopic tight ventriculostomy, and of course ETV-CPC, which is currently getting a lot in so many countries. There are certain peculiarities in low and middle income countries. First of all, perception of hydrocephalus in low and middle income countries. People still feel that a hydrocephalic child is a spiritually abnormal child, and there are things that are associated, and that perception leads them to come to the hospital late. That perception also leads them not to even seek for medical treatment, you know. So cost implications, again, when you look at, you know, LMIC peculiarities, yes, in terms of getting that. And I will share a story, a very story at the end to show that the role of infection, especially in LMIC countries, that is really a very, very big problem. So for me, what is the objective of this discussion is to take you through a historic background for the Gambia. Where are we now, and challenges and way forward, and how can high-income countries help LMICs? And I think that's one thing I want to achieve here. So this slide just shows the Gambia before we have a sitting neurosurgeon. And I'm not going to delay much on it because the next presentation is going to talk about Sierra Leone, who currently are at that stage. So a professor by the name Professor Saho comes from Senegal, you know, and he runs missions. We call them Banjul Neuro missions. And he did about 13 of them with 70 surgeries. And most of these were hydrocephalus patients that were operated. But of course, you know, as good as it may be, if they go back and complications happen, is always an issue. When we looked at our data now, I would say this disclaimer that it's very difficult, and Magnus have known those of you that have come to Africa. It's always so difficult to do any retrospective study. You know, getting the files, getting the folders, it's always a big nightmare. However, whatsoever we've been able to gather, looking at it from 2019 to 2020, 25 or 26, so a total of about 239 cases, you know, were done. About 28 EVD folders were found, and ETV CPC, we had 18 that was done. So timelines, I would divide this talk into a time before a period 1 and period 2. And a period 1 was a time when we don't have the ETV CPC, and so all our patients that we see were actually treated using a shunt, whether it's a triventricular, tetraventricular, hydranencephaly, were all treated using shunt. And then the second period is when we then start, you know, with the ETV CPC, and I would want to show that to you. So just to go on the first period. So if you take a look at the first period, you know, in January, I mean, you will realize that, of course, you know, we have a total of 168, you know, ventriculoperitoneal shunts that were done, and EVDs, you know, accounted for about 26, you know, cases, you know, that were done. And if you look at it, I mean, yearly we are, you know, around that 30s, you know, going up to 40s in terms of cases. But again, like I said, it's about folders that are found, you know, that we are able to do this work on. And then when we look at the second phase, which is the second part, it's where we have the, you know, the ETV CPC, and we started that in September 2025, and up till today, you know, if you look at what we did, we were able to have about 30 cases of ventriculoperitoneal shunts, about 18 cases of ETV CPC, and about 12 cases, you know, of EVD. Now, peculiarities about low and middle income countries. One, our human resource is low. And because our human resource is low, we work on developing the task shifting and task sharing. And this is something that I really take a lot of pride in, because it's something that I had to do so that it can be able to help me, you know, focus on other things. And if you look at this, and that's the interesting thing, if you look at the number of VP shunts that are done, almost about 37%, you know, of those VP shunts were done by non-neurosurgeons. And even today in my unit, even though we have a number of neurosurgeons, they still do that because we've taught them to do that. And EVDs also, you know, almost about 20% of them were done. A second peculiarity, again, that is important was how do we adapt ourselves to the external ventricular drains, which, number one, we don't have easily. Number two, if it is available, it may be expensive for the patient to have. And so we then developed this whole technique of, just because, you know, we had a donation of intraventricular catheters. And so that's what we now use. Not all of them, but we've started this using intraventricular catheters and just making what we call intermittent CSF withdrawals for people that have gotten a shunt infection. And for the first time, that's working very well. So if you look at the picture on the far right, that was a patient that, you know, we did an EVD for a long time. Of course, we don't have all the items for the EVD. Now we do have some of them. And by the time you came back the next day, you realized that the CSF that is in the bag was more than what the patients had. You know, that's basically how I would say it. And that's actually what led us to develop this new thing. And hopefully we are trying to look for it, and we will obviously publish it. We know the problems, of course, of subdural collections, you know, any other thing, we know all those things. Now then we go on to the third part. So I'll be happy to say that the first team that came to the Gambia to do an endoscopic third ventriculostomy was a team that came actually before COVID started. This was from Charité Hospital, Berlin. I met this team in Tel Aviv during the ISPN, and they said they were going to come, and indeed they came, and that was the first time. Unfortunately, it was the first and the only time, and they were the first to do it. The second team that actually did an endoscopic third ventriculostomy in the Gambia was the SANG team. SANG, the president, of course, is Magnus, we all know, and the team was headed by Jimmy. And you know, you could see they've been of great help to me and to my unit, and then we did that. And then we also had some things that, you know, we got some kind of scopes that we are in too good that we were only able to do CPCs for, specifically for hydranencephaly. Then came the other, which is the ETV CPC, and the team that brought that really was the Brigham and Women's team, you know, led by Prof. Smith, who had that discussion with the NeuroKids team, and the NeuroKids team brought it. So Dr. Bankole was the one that was sent to the Gambia to come and train us. And because of my, you know, in and out, so I decided to take one of our neurosurgeons, who is Dr. Jane, that you can see me, Dr. Bankole, here, and this is obviously Dr. Jane, and Dr. Jane was the lead person who was actually trained by Dr. Bankole. Now, let's look at what happened and when we started doing that. So the missions were in September, in November, December, and also that gave us a total of 3 missions. And we had, you know, in the first time we had 4 cases, the second mission they had 4 cases, the third mission was like 1 case, and we were all able to do the cases. So this is my OR. Those are the items that they have brought, and that's Dr. Jane obviously doing an ETV and ETV CPC. So in total, we had about 18 ETV CPC, and within this period, we had also about 30, you know, VP shunts that were done. And then we then move on to looking at what our results were, by the way. And so if you look at the results from, you know, age of less than 6 months, you know, we had almost about 17 out of 30. Between 7 to 11 months, we have 7 out of 30, and in terms of ventriculoperitoneal shunts, while ETV was about 4 out of 18, 8 out of 18. So we've started doing quite, you know, a number. Now, if you look at our post-operative complication infection rates, with our shunt rates, we do have a kind of a pretty high infection rate, about 23%, 0.3. But with the ETV, we had about 2.8. So the future really is great, and we hope that we should be able to do more of the ETV now that we are doing. Complications of shunts common to everybody, and everyone know extrusion and all that, and that's again now here. If we look at most of the literature, we know that, like for instance, low-income countries, we use, you know, fixed pressure shunts, such as the Shabra shunts. Now we know that comparisons have been made, you know, research have been made about, you know, outcome of the different type of shunt, programmable or non-programmable, and all that. But then if we obviously do have this, and we know that the difference is not really so much in terms of the type of, you know, the type of shunt, especially programmable or non-programmable. However, what then would help in terms of a low and middle income country is for them to be able to have, like what has been done with the NeuroKids, and the NeuroKids being able to provide, you know, that treatment modality. And if we are able to have that treatment modality for ETV CPC, and we are able to have the shunts, then we can be able to treat all the patients and almost get to a HIC level. And I don't think the difference will be that significant. So again, you know, this is a story of a patient that we saw, we managed in our unit. He had a myelomeningocele. We did the repair, and he had a hydrocephalus. We needed to do the surgery, and the family couldn't have the money, and they went out of our view. We didn't see them. They only came back when the head was too big, when so many things happen. You know, these are things that could have been prevented. Yeah, so in conclusion, let me say that we know that ETV CPC is very, very effective, regardless of the etiology. Of course, much more in obstructive hydrocephalus that we know. We know that its post-operative infection rates are markedly lower And we do hope that we can be able to, now that we have started that, and hopefully when we present our next series, we should be able to have a lot of lower infections. Shunt dependence, in our own case, about 72.2% of ETV-CPC patients achieve a shunt-free status at 3 months, and which is obviously very, very important. And of course, finally, is to say that the opportunity to treat hydrocephalus with a single operation that avoids shunt dependence is of particular value in low and middle income countries. So I think that in conclusion, one of the things I would say would be that we are also lucky to have some support groups, which is the Lamin Keita Hope. We were also supplied with Child Help International, and they provide for us 100 shunts. So currently in the Gambia, the status is that we have shunts, so we don't have delays in terms of treatment. Patients don't need to go and wait to get the money to be able to buy the shunt, because the shunts are available. And this is possible courtesy of Child Help International and also the Lamin Keita Hope, and the ETV, CPC, everything being provided by the NeuroKids. I want to thank you all for your kind attention. Thank you.
Thank you, John. You were very much in time. It's very interesting. So we save all the questions, and I can't see any questions yet in the Q&A. So next speaker is from Sierra Leone, but is currently in Venezuela. He started his career when there was no neurosurgeon at all in Sierra Leone, but still he wanted to be a neurosurgeon, so he crossed the Atlantic and ended up in Venezuela, and is almost finished his residency there now. So, and I had the opportunity to greet him in Sweden last year. And I'm very glad that we could participate. Tejan, we can't see you, but we can hopefully hear you.
Thank you very much, Prof.
Yeah.
Thank you, everybody.
So please go ahead.
Good morning, still in Venezuela, but I'm sure it's good afternoon in Europe. I'm Foday Mansaray. I'm a Sierra Leonean. I'm a final year resident, neurosurgery resident here in Venezuela. Actually, I lived and practiced in Sierra Leone, worked in the Department of General Surgery, and worked with Dr. Levy, the only pediatric surgeon in the country. So I pretty much have had an experience working with him. Let me share my presentation. Okay. They should be okay. Is it visible?
Not yet, but sometimes it takes a little bit. It's not yet visible. Not for me, at least. It seems to be very dark in Venezuela. It's just a black screen.
All right, let me come again.
It worked before, so hopefully. Have you stopped sharing, John? Not...
Yes, I've stopped sharing.
Oh, good.
Is it visible now?
Still not. No. It's a bit strange because we saw it before.
Now?
No.
Oh.
No, strange. If it's too problematic, maybe we could go to the next speaker, Jehuda. Do you think so? And we can solve it. You can solve it. Yeah.
Okay.
Okay.
So we come back to you, Tejan.
It's all right.
So it's my pleasure to introduce Dr. Michael Dewan. Michael Dewan is a pediatric neurosurgeon in Vanderbilt University, and also part of the NeuroKids initiative, and actually the board director of the NeuroKids initiative. And this will take us a little bit to a perspective of how we, from high-income countries, can help or maybe assist and low middle-income countries, specifically also in hydrocephalus. So, Michael, thank you very much for joining us, and excited about your talk. Oh, now the Sierra Leone presentation is on. Let's see, we might need to adjust.
You tell me. Let me stop sharing.
Tejan, we see your presentation now.
There was some lagging, so please go ahead. Put it in presentation mode, yes, and go ahead, Tejan. seems like it's a slow net. Tejan?
Tejan, you are muted.
And now?
We see your presentation.
Yeah.
Can you hear me now?
And we hear you, yes.
All right, thank you so much. Sorry for the inconveniences again. I'm Tejan Mansaray. I'm a final year neurosurgical resident here in Venezuela. I'm a Sierra Leonean. Have lived and worked in Sierra Leone. I worked in the Department of General Surgery and later with the pediatric surgeon in the Department of Surgery. So I'm pretty sure I have had some experience working with him. And we all know Sierra Leone it's a small country still in Africa without any neurosurgeon, and probably we're becoming very famous for that now. So we already know that there's a huge burden in terms of pediatric hydrocephalus, and which is why it's always good to talk about it. We know that in sub-Saharan Africa, we globally we account for almost half of the pediatric hydrocephalus load in the world, and over 200,000 new cases, infant cases in sub-Saharan Africa, accounting for 47% of all pediatric burden across the sub-Saharan region. And we know that the congenital incidence of hydrocephalus is twice as much in Africa compared to US and Canada, and there are up to now less than 15 fellowship-trained pediatric neurosurgeons in almost the entire Africa, with an approximately 229 million neurosurgeons for almost 400 million people, which means roughly one neurosurgeon per 1.7 million people. The etiology in terms of hydrocephalus is slightly a different pattern compared to high-income countries. Post-infectious hydrocephalus and congenital hydrocephalus, cause of it is still the leading cause. Nigeria accounting for 44% in aqueductal stenosis, Ghana and Burkina Faso with malformations, CNS malformations. Sierra Leone, we don't have any qualified, let me use that word, statistical information about that, but we have a retrospective data that I will present later from the University of Sierra Leone Teaching Hospital Complex. Generally, they all present with macrocephaly in 80% of the cases. You have the bulging fontanelle, vomiting, sunset signs, and developmental delays. What is peculiar about Sierra Leone or our public health sector? It's still a small nation, less than 10 million people. We have approximately 8.3 million according to the last census they did, with 2.4 doctors per 100,000 people. And the vast majority of this population are the junior doctors. They are not specialists. There's only one medical university in the country, which means the gap in terms of service delivery and surgical care is still very huge. There's no neurosurgery residency training in the country, and most of the times the pediatric referral cases are mostly neurosurgical in 48% of the times. So this is a retrospective data from the University of Sierra Leone Teaching Hospital Complex, in which in the last 5 years, they've reported that 185 cases, which means 48% of the pediatric cases were pediatric hydrocephalus. And traditionally, they've been managing it with ventriculoperitoneal shunts when the shunts are available. We also have neurotube defects, traumatic brain injury, and other congenital anomalies that are still a huge concern in the pediatric sector in Sierra Leone. So the options they have, generally, we have the ventriculoperitoneal shunts. In a pooled study, in 83% of the cases, they are being shunted. The good thing about the shunting is it's familiar. It's a familiar procedure that you definitely do not have to be a neurosurgeon to do it. As a matter of fact, the only person that is doing it in Sierra Leone for now it's a non-neurosurgeon. It works for every other etiology, whether the hydrocephalus is a communicating or non-communicating hydrocephalus, and the Chabra shunt is also what they're using in Sierra Leone. It's relatively cheap. even though most of the time it's been donated. The point is it's a lifelong dependent procedure, and most of the times they're being complicated by infection, and there's also a risk of revision always. SANC started doing endoscopic third ventriculostomy, the team led by Professor Magnus, and they did it in quite a couple of cases in which it was successful. The good thing about it is it avoids a permanent placement of hardware, and if it works out, there's a chance of a single intervention, and it has been confirmed or validated in Lagos, in Nigeria, and the Uganda studies, the cure protocol they did. Sometimes you can associate it with choroid plexus cauterization. The bad thing or the limitations is that you need the endoscope for it, and you need a surgeon learning curve, the experience for that, which we still do not have among the local Sierra Leoneans to do. The complications generally is the same throughout sub-Saharan Africa. It's been dominated by infection, but then you still have other complications in terms of the patient follow-up, in terms of the revision, risk of revision, surgery revisions because of shunt malformations, deformations, etc., or dysfunctions. So there hasn't been any difference, and there's a randomized control studies that was done, I think, in 2024, which didn't show any difference at 5 years post-surgical resolution between the third and ventricular endoscopy and then the ventricular peritoneal shunt in terms of brain function, brain volume, and cognition. So, which means, like Dr. Jabang said, it's a breakthrough, and it's a procedure that can help really relieve the burden that we have in sub-Saharan Africa. So generally, the patient journey in Sierra Leone is that it's a neonate that will present sometime with untreated bacterial sepsis or severe septicemia, and then they later develop ventriculitis, rapid head growth, circumference growth. They present on late admissions because of the traditional belief that we have that probably these patients are related to witchcraft or it's a curse or some other form of belief that it should be treated traditionally. So they later present to the Connaught Hospital on late admissions with severe macrocephaly. And obviously, because we don't have these shunts available always, we have to schedule the intervention. So which means the patient will have to return to the remote village, which is far off from the capital city, and then leaving them highly vulnerable. Most times they'll die, or when they return, things are worst. So having considered that SANC have been doing the endoscopic third ventriculostomy, comparing to the other studies they've done in Uganda, we now know that there is probably no much significant difference between the VP shunts and then the ETV at 5 years in terms of brain function, which means we have to individualize the context, the patient, about what is available at hand to treat the patient and which is good for which patient and which is good for which pathology. Because the primary damage has already been established, and surgery is not going to be a novel in reviving the neurological function of the patients. Instead, we have to individualize the condition. So we already know the workforce is still deficient in Sierra Leone specifically because we still do not have any neurosurgeon. Nigeria is far way ahead with almost more than 120 neurosurgeons because they have 11 accredited training centers out of the 27 accredited training centers in the West African College of Surgeons. Ghana has 25 approximately, Senegal, Cote d'Ivoire approximately 50, Mali 17, Burkina Faso, and obviously Sierra Leone we still do not have. So Sierra Leone's provide a model. We have only one pediatric surgeon who is Dr. Ealebi. Dr. Ealebi was trained in East Africa, I think with the Koseseka. And obviously being the only pediatric surgeon operating both neurosurgical cases and non-neurosurgical cases means he operates under enormous pressure in terms of there's only one theater for him in which he shares the peritonitis cases, the general pediatric surgery cases, the orthopedic cases, and then the neurosurgical cases, coupled with the fact that there's only one person, but the theater setup is probably not ideal one to avoid the complications like infection. So our training and capacity building that we have, dominantly the surgeons are being trained in Sierra Leone with the West African College of Surgeons. Of late, in the last 5 years, we now have the Sierra Leone Local College of Postgraduate Training, that has been helping with training local personnel. So the West African College has 24 accredited sites in 7 countries. Sierra Leone has 1. We are trying to use the other facilities, like the private facilities like Tejan, to help us expand the training institution. You have CURE in Uganda, Benin, Abidjan Lab, Pan-African programs, and then the other new programs from the Burkina Faso and Cameroon, all trying to help in the sub-region to help increase the manpower. The common management challenges in Sierra Leone, I have mentioned, well, directly or indirectly. One is the long distance travel for families. Most of these patients, they come from provinces, they don't have transportation means, or probably they don't have finances to come to the capital. The cost constraints in terms of high cost of imported shunt systems, the health workforce training in terms of tax sharing and structures. We have poor work remuneration for the health workers. There is this CAPA care in Sierra Leone that trains local doctors, medical officers, and community health officers in terms of tax sharing and essential surgical emergencies, but they have not been trained in basic neurosurgical procedures. One can say it's basic because, well, maybe you don't have to see too much of blood in placing shunts, but yes. And then most importantly is our delayed action that we have in Sierra Leone, the social stigma, the cultural acceptance that we still have towards hydrocephalus and generally central nervous system malformations. We believe it's deeply related to traditional beliefs and obviously diagnostic errors because of the personnel. Our way forward, we probably can incorporate a few protocols that have been adopted in other places, like the CURE protocol from Uganda and Nigeria and Mali. Advocate for folate fortification, expand our training facilities, prevent post-infectious cases, strengthen our neonatal sepsis, surveillance and treatment, standardize low-cost shunts. The Chabra so far hasn't proven to be inferior to other big named labels like Medtronic or Sparta, etc. We have to also improve our regional registry, web-based multi-century track presentations, intervention, infection, and mortality neurodevelopment controls. These are both local and international partners that we've had. In terms of, can you hear me?
2 minutes left. Yes.
All right. In terms of international partners, we have the SANC, we have Mission Brain, and there's an orthopedic surgeon, Dr. Aliu Kamara, has been helping with neurotrauma cases, and Bethany Kids also donating the shunts. Neurosurgery residency, for me, the plan is to complete the residency training currently and help restructure or set up the neurosurgical unit at the Corners Hospital, which is actually it's a process that is already kicked in. Train our colleagues, our regional colleagues in Sierra Leone and help how we can get things better, improve our investment in service delivery and health infrastructure. These are a few instances in which I've been doing the pediatric neurosurgical cases here in Venezuela, hydrocephalus, this was a spine case, and then there's a brain tumor on the other side. Sierra Leone is a beautiful country, West Africa, on the coast of West Africa, partially with a view of the Atlantic Ocean, beautiful beaches, and then nice people. You're always welcome to visit anytime. Thank you so very much.
Thank you, Tejan. I really want to come back looking at these images. Thank you. So please write in the Q&A questions. I see the first one has come.
Excellent.
Okay.
Thank you very much. So after hearing two speakers from low middle income countries, as I said, we will move on to how we as high middle income countries maybe can help. And Michael Dewan, I introduced already, and he will talk about the NeuroKids initiative and how they managed to help in Africa. Thank you, Michael.
Thank you. Are you able to see the full slides there?
Yes. No, it's good.
Yes.
Perfect. Yeah.
Great. Thank you. Well, it's great to be with you all. It's a real honor to join this group and some really wonderful faculty to join. So my name is Michael Dewan. I'm a pediatric neurosurgeon at Vanderbilt, which is in Nashville, Tennessee in the US. And we'll talk for the next 12 minutes or so about this organization, NeuroKids. We've heard a little bit about some of it from the previous two speakers. And I just want to say the following, and I thought Dr. Jabang said this well, the comment of standing on the shoulder of giants. And I credit people like John Mugamba from Uganda and Ben Wharf from Boston as individuals that have certainly been influential. And this talk, what you're going to hear, is from me, but it is certainly on behalf of a huge team of people that are doing this work. And so NeuroKids, this is a nonprofit organization based out of the States. And our mission is to make it possible for children with hydrocephalus and spina bifida to live better and longer lives. And we do that by partnering with people like you, with neurosurgeons, with hospitals in low resource settings, providing education, training, equipping with things like endoscopes and connections to shunts, providing mentorship and support. And so I want to spend some time talking about what that looks like practically. We know that there's a large burden of disease, about 5 million children worldwide that live with hydrocephalus, about 400,000 new cases each year. And a lot of these patients don't get diagnosed, they don't get treated, and they die or live with severe disability. I'm not going to spend a lot of time talking about the burden of disease and the data behind that, but just to say that we know that there's a huge volume of hydrocephalus patients, as we've heard, and as we know, too few neurosurgeons to address that. And one of, not the solution, but one of the solutions is to improve our education and training. And so we do that by, in part, conducting comprehensive longitudinal remote presence training for neurosurgeons in hydrocephalus. And really what this looks like is, what I'm talking about is a confined program that's mostly, not exclusively, but mostly designed to educate and train in endoscopic third ventriculostomy with choroid plexus cauterization, in effort to reduce the burden of shunts that we know and we've heard can get infected and obstructed, and in settings where getting to a hospital quickly is not possible or feasible. So since we started, there have been about 3,500 cases across 18 countries, a lot of hours of surgical mentorship and remote mentorship training. And so let's talk about how this works practically. So we used to kind of this middle box. When we started off, we would target surgeons in hospitals that we knew had a high burden of disease, but we don't really do that anymore. Most of our connections with surgeons in hospitals come from them reaching out to us. Maybe they've heard about us at a meeting or other ways, and they reach out to us and say, "Hey, listen, we've got a lot of hydrocephalus kids. We're interested in training in ETV CPC. How can we make that possible?" And so then they fill out a number of forms that help us understand their volume, their OR capacity, prior training, We try to understand who their bosses are, who's in their administration. Is their hospital going to be supportive of this? How much do they or do they not support the care for pediatrics or pediatric hydrocephalus, so on and so forth? Because we've learned a lot, and we've made mistakes along the way and tried to figure out how to make this better. This is the kind of where we work and where we have worked in the past. It's not a completely up-to-date map. DRC is a newer site. But this is generally what the training model looks like. It occurs in 4 phases. All right. The first phase, this is after we've identified a surgeon or a group of surgeons at a hospital and understood that this would be a good partnership. We start with the basics. These are webinars, just like kind of what we're having right now, where we assume nothing and we talk about what's hydrocephalus, ventricular anatomy, what are the treatment options, and then we get into the weeds of patient selection, who's going to be a good ETV CPC candidate, who's going to be a good shunt candidate, and then we talk about the details of performing surgeries, videos, etc. And then we do a clinical on-site visit. In the past, what this would look like is we would fly a surgeon to Mbale, Uganda, and they'd spend 6 to 8 weeks with us, doing a lot of cases, getting really good at ETV CPC, and then they would go back for reasons that we don't have time to talk about. But there were some reasons why surgeons wouldn't necessarily be able to continue that work, and so we felt like it would be best to go to the surgeon, him or herself, and train with them at their institution in their environment. And we usually do that for somewhere around 5 or 6 days, knocking out a whole bunch of cases, again, mostly ETV CPC cases, with the goal of generating a safe surgeon, not an expert surgeon, but a safe surgeon that can get out of trouble, with the knowledge that in the subsequent phases, we want to produce an expert surgeon. And this is, you see Gambia down here. Let's see if my screen isn't completely showing, but generally what you would expect in terms of what clinical on-site visits look like. Importantly, during those on-site visits, we set up the remote presence technology equipment so that we can engage in that remote presence training, which I'll talk about here in a second. We don't really use the glass view very much. It is helpful for some open cases, but for most of our hydrocephalus work, that's not been necessary. Maybe the most important thing is this individual right here and what she represents, our clinical care coordinators, where all of our newer sites, we invest in an individual that is tagged to the neurosurgeon or the group of neurosurgeons there, and their role is simply to be with these patients, these families in clinic before and after surgery, and in follow-up, helping the surgeon who's running around, have plenty of other things to do, collecting data, things like that. These individuals, the clinical care coordinator, maybe the most important thing of everything that we're doing. They've been tremendously valuable. Then the third phase is the remote presence phase, and this is really the meat of the program here. And what this looks like, this also sort of comes in 2 different forms. There's a patient selection phase of this remote presence mentoring session, which usually takes place over 6 months. And then there's the actual intraoperative guidance. Regarding the first phase in the patient selection, we do this all via REDCap. So if a surgeon in Liberia has a patient in their emergency room that's got a big head and maybe big ventricles, they can pull out their phone. Hopefully they have a smartphone, pull out their phone, fill out some patient data, snap some photos of the ultrasound or the CT scan, or in rare cases, even an MRI, and that uploads to a cloud. And that goes to myself and 4 other neurosurgeons, John Mugamba, Ben Worf, and a couple other surgeons that will review these cases in real time. I have a toothbrush there because I usually review this when I'm brushing my teeth in the morning, because I usually came in at 2 a.m. or 3 a.m., in a different time zone. And we just quickly go through it and give feedback and say, hey, listen, great candidate for ETV CPC, go for it, good luck, and let us know when it's going to happen. Or I think the anatomy here is going to be bad. I think you're going to run into some problems. I wouldn't do that. I would put a shunt in, or maybe try an ETV CPC, prep the belly though, because you're going to need, there's a chance that the anatomy is going to be unfavorable and you'll need to put a shunt in. That kind of dialogue where it's in real time, they get immediate feedback and they don't have to take the advice. And sometimes the advice is different. Sometimes all 5 of us might not be in full agreement, and there might be more than one reasonable way to treat a patient. The other component of the remote presence mentorship, and again, the meat of it, is the intraoperative virtual presence feedback. So we'll dial into these cases and be with the surgeon as he or she is doing the case. That's what you're seeing on the left screen here that I'm showing you. And I do this in my office here in the States. We'll give this feedback while we're doing the case together. The screen on the right is where I'm essentially grading the surgeon on a variety of different metrics. And this is what those metrics look like. There's a checklist of steps. There's a technical skills rating scale, and there's errors. And what you're seeing here is these graphs, time is on the horizontal axis. And what we want to see is that they're doing each of the steps better and better over that 6-month interval. Their technical skills are becoming more fluid over that 6-month interval, and we want to see the errors essentially go down to 0. And this is not yet published, but we're working on it. I want to take a brief moment to talk about what we kind of call our bench of trainers, and illustrate what that looks like here. So this is Alvin in Liberia, who I was with last year. Fantastic surgeon. We finished our on-site training. He WhatsApp messaged me, "Hey, I've got a case. It's scheduled for this period of time." I was tied up in theater. I was going to be in a case all morning and all afternoon. I couldn't do it, and so we bumped it to our global bench. And Femi wasn't able to do it. Femi Bankole, who we heard earlier about, he was also in theater. John Mugamba in South Africa, he was sick, but our Ugandan colleague was the one that mentored, and that's what we want. I mean, we'd like to put ourselves out of business, and it just works better with somebody like Peter Senyonga from Uganda mentoring, a case in Kenya or Rwanda or what have you. It's just probably a better way of doing things. Also, it saves me from waking up at 2 o'clock in the morning here in the States. And then what we really want is the trainee to become the trainer. So by the end of their 6 months, we want them to be an expert and to then go on to train. And this illustrates that well. Our experience in Brazil with Giselle Coelho, who we trained a couple of years ago. She got really good at the procedure, and is telling me about patients. Hey, patients are doing well, kind of following up in that way. And then one of her colleagues in Amazonia with a lot of hydrocephalus patients needs training. Now, we could do all of that training ourselves and spend time going back and forth, but it makes a lot more sense. I don't speak Portuguese. Giselle is a fluent Portuguese speaker in Sao Paulo. And so it makes a lot more sense for her to do the remote presence mentoring for her colleague, Simone, who's up here in Amazonia. And that's exactly what they did and what they're doing. And what we're seeing is, them sort of celebrating Giselle from Sao Paulo, providing the remote presence mentorship to Simone, who's in Amazonia. And completely, I was not involved. I was just happy to see that they didn't need us anymore, and they were able to do this on their own.
2 minutes.
So let's see. I heard a 2-minute warning, so I want to actually ideally end sooner. But that gives you kind of a general flavor of how that program works. I encourage you to, if you want to learn more, feel free to reach out. My email's here, but also feel free to go on our site, and we'd be happy to hear from you and be in touch. So thank you for your time.
Great, Michael. Thank you very much. Fascinating work, fascinating talk. I remind you to put questions in the Q&A, and we'll move on to the next speaker, which is Professor Martina Messing-Jünger, which we all know very well. She's a known pediatric neurosurgeon working in Germany, and also involved in some project in low middle income countries. And I'm happy that you're here, Martina, and she will talk about treatment of pediatric hydrocephalus in low middle income countries, differences to high income countries, and how can we help improve education and resource. Thank you, Martina.
Yeah, first of all, I am very happy that we put together this very important webinar, and thank you for being in the faculty and also for the audience and the interest in it. And the disclaimer at the beginning, all the individuals shown in the slides gave their consent for publication, of course. So we have heard a lot of possibilities, how we can improve the education and also the resources. And I would like to give you a view on my very personal experience in a little bit different country. So we have heard about all the significant differences in etiology and presentation between the global south and north. I have not go through it, and also the problems, high incidence, insufficient number of surgeons or neurosurgeons, and the limited infrastructure, of course. And we also have heard about the figures that show exactly the situation. So I can skip this, but that comes now to my topic, which is the experience of hydrocephalus treatment in children in Eritrea. And Eritrea is one of these countries. You can see here in this graph, everything which is red has 0 up to just a handful of neurosurgeons all over the countries. And Eritrea is just one of these countries with 0 neurosurgeons. And it is located at the Horn of Africa. Here you can see the capital, Asmara. And the political situation of Eritrea is very specific, and it is a more or less completely isolated country. And exchange for education, international networking, internet access, and so forth is not possible in this country. And this makes education and improvement of the local situation even more complicated to what we have heard before. So the experience of my team and me is now 10 years old. We started in 2016, and since that time, even partially during the pandemic, although during more than 1 year it was completely locked up, we could not go there. We treated about 80 cases per year, and of course the majority was pediatric hydrocephalus, also combined, of course, with spinal dysraphism. And from the beginning, for us, the most important aspect besides treating the children was, of course, continuous education for all professionals, not only surgeons, but any other involved in the management of hydrocephalus and other neurosurgical surgeries. We also established a screening and follow-up program with the local forces, and we're bringing a folic acid salt fortification project on the way, and finally we expect that it will be finalized during the next year. The infrastructure we are working there is a dedicated surgical unit which is located inside the National Referral Hospital in Asmara, and it is called the International Operations Center for Children in Asmara, where not only neurosurgery but all other surgeries are performed by an international team from Germany, Italy, Switzerland, Austria and Denmark. And it is run by a very small German non-profit organization because Eritrea does also not allow larger authorities or organizations working in their country without controlling them too much, and this is quite a problem. This IOCA has 3 operation rooms and its own intermediate care ward with 12 beds, which are usually used by 2 patients and their mothers each. And here you can see the teams working there. The technical equipment is quite well. We have our own sterilization unit, microscope, endoscopy, ultrasound, and access to CT and MRI, blood bank, and microbiology from the Orota clinic. And this is quite a rare thing, I think, in most sub-Saharan small countries, that there is very easy and free access for the patients to imaging. Postoperative ventilation in certain cases is also possible, and of course we have an independent water and power system, since the supply in the city itself is terrible, and you could not have safe surgery done without this. All the consumables we are using are imported by us, sometimes even by hand. Here there are some impressions from the ward patient, and this here is the building, an old colonial building erected by Italians during the colonial time. Here you can see the Eritrean German neurosurgery team, and we have of course the typical cases we have seen before, but also very specific challenges. This here is a child with a very severe sunsetting and microcephalus presentation. We have a post-traumatic hydrocephalus with a growing fracture, 2 years left untreated. And also nearly daily we see cases like this, secondary hydrocephalus in incredible encephalocele. Of course, this here is a more typical condition, which is naturally quite different from the cases we are operating in the global north. But now let us quickly go through the way how we are working there. So we start with patient screening and setting up the OR schedule. We see in each screening period per year 100 patients and their families. And there is a nationwide patient recruiting, which is organized by the local staff prior to our arrival. So they come from all parts of the country, and the screening is performed together with the local doctors and nurses and our anesthetists, because they have to do a first check regarding the operability, of course. And we trained the local staff to perform a pre-selection according to the diagnosis, which will facilitate the risk scoring, which inevitably has also, in some cases, triage as a consequence, which is, of course, a terrible thing, but we have to very well tailor what we are doing there. And then, after having seen all the patients, not earlier than this, we are setting up the OR schedule together with the local staff, taking into account all resources we have inside the IOCA and also in the environment. And you can imagine that the first days with the screening and probably some patients that cannot be offered a surgery because we would never have a chance to improve the situation, and even worse, it would deteriorate the patient and the family's condition. This is something we are facing there because our slots are never longer than 10 days. Then the screening is followed by preoperative management with basic lab infection assessment, blood type, blood unit if needed, which is available, additional imaging, and of course oral informed consent by the local doctors, and the final pre-medication check by the anesthesiologists. And if you have infected cases, they will put under preoperative antibiotics, so we try to perform surgery afterwards. When we have complex cases, we are doing them by ourselves. The regular hydrocephalus cases will be done as training cases. We have so far educated or trained 9 colleagues, but unfortunately, 4 of them left the country for political reasons. So we always restart our education program for shunting, which can be performed on their own in our absence. But the colleagues are very much involved in this and passionate, and they try to do what they can do, and they are supplied with shunt systems by us. Unfortunately, we cannot so far let them do endoscopy. This has something to do with the fact that the operation unit where the endoscopy system is located cannot be transferred or cannot be used by them in our absence, because other surgical teams are there. But we will find a solution in the future, because they are trained to do this, but only when we are there. But so far they don't have the chance to have ETV and eventually CPC done when we are not there. The instruments are very basic out there in order to keep it also safe in the maintenance. So we are teaching the colleagues there in all aspects regarding diagnosis and evaluation of the patients, preoperative management, and also hygienic standards, of course, specifically due to the implant situation, instrumentation management, the surgery, of course, complication management of surgeries, post-operative care and follow-up. And all the time we are facing the same as back home, of course, technical, not only medical problems, and problem solution is something they are learning from us. But on the other side, we are also learning from their sometimes very practical way to solve problems. And this works very well, since everyone is highly motivated and even works on Sunday when called out of the church when something is not working, like the autoclave. The postoperative management consists of follow-up period in our IMC ward for several days, depending on the diagnosis, which is totally run by local staff, very well-trained nurses. All of the kids receive 3 days of postoperative antibiotic prophylaxis. We have 2 daily rounds and imaging or lab tests if necessary after surgery. And a final post-op control is performed prior to our departure back to Germany together with the local staff. And then we are identifying and registering patients that seem to be at risk in the near future for further appointments with the local doctors.
2 minutes.
Patients on discharge day. So finally, what is most important in supporting pediatric hydrocephalus treatment in LMIC? First of all, I think this is something I need to address to colleagues of mine that want to work there: the prevention of additional harm to patients and families. We always have to start our indication setting with the question, is there a realistic chance to improve a child's condition with acceptable risk, specifically in a country like Eritrea? Always consider possible long-term complications and respect the local conditions, also religious, ethnic, and social aspects. And long-term follow-up for evaluation is important. We are doing this. We do not have reliable statistics, but we see approximately 3/4 of our patients also years after the first treatment, because they have a very high compliance and come back for follow-up. So what is feasible? So here you can see, somewhat minimal invasive shunt implantation in order to maintain this beautiful hair of this little girl. She did well. This here is 1 year follow-up. And even this child we have seen before took advantage from getting shunted. Of course, it is debatable, but the child improved even with the macrocephalus and specifically with the eye function, and started to talk, something we did not expect from this very thin brain mantle which was left. And the child is loved by the family, which is very important. And this is a baby, an ex-baby we operated also with a hydrocephalus like this. And she did very well, is now a school girl, and the macrocephalus is less significant. What else is important? Providing, of course, sustainable support of any kind with adequate OR and ward standard, technical equipment, maintenance support, hygienic standard implementation, consumables and implants provided by us, and ongoing education of all local professionals, and establishing an interdisciplinary healthcare network for the awareness and care of hydrocephalus patients. And we are offering remote counseling, but not in such an elaborated way as the NeuroKids can do because of the restrictions Eritrea is giving us. So it works with telephone or sometimes an email, which is allowed by the government. This is very difficult, but we can handle cases like this. And very important, when you have also problems with the government, cooperation with local health authorities is something we have to do constantly when we are there. Thank you very much for the attention, and I'm happy to answer questions.
Great. Thank you very much also to all the speakers. So I think now we will open the discussion. Magnus, maybe I'll read the first question and then
go ahead.
go on.
Go ahead, Jehuda. You go ahead.
So, John, I don't know if all the speakers are hearing me. I hope. John, the first question is for you, and I think it's a general question which I also was asking myself. Is there a greater need for healthcare worker training, improved access to radiological research, increased availability of shunts for patients with hydrocephalus, or other form of assistance? I think the question is, we ask ourselves, what is the thing that we can help the most? And I know Michael has a lot of experience and they learned over time, but maybe from your perspective and maybe Tejan's perspective, what is the thing that you need the most from us, from our countries?
Yes, well, thank you very much for that question. And I think the things that we need the most, I think I would divide them basically into probably two things. One, it's obviously training, getting in touch. And I think the model that NeuroKids is using is one great one. And it's a similar, different from the other model that the SANC is using. You know, you come and train the people that are there and provide for them the things that they need to treat these patients. Because, for most of low middle income countries, the hospitals don't buy these items for them. Like, for instance, I've practiced in the Gambia for the past close to 10 years now, and I can't tell you any single item that I've been able to get from the hospital or from the ministry or from the government. And everything that I have in my OR is from collaborations that I have. So talking about hydrocephalus more, I think going by the NeuroKids system, they get you all the stuff that you need. They come there and train you on the ground. And I think that's absolutely very, very, very important. And then from there, they don't only leave you alone, but they also help to keep track of what you are doing. So I think those, for me, would be one of the best ways to do it. And I think it's a similar thing that SANC also does. They keep that contact. They send you what you need. They come down. They walk with you, and they also follow that up with you. So I think that would be the thing. When it comes to the other, which is getting the materials, the shunts, it's not also very sustainable. Yeah, I mean, if the people do have the shunts, like Child Help International is doing, so now they've sent us like 100 shunts. So now kids would not delay just because they don't have the money to be able to buy that. So once they come, we have the discussion on the red cap, and then it's ETV we do. If it is a shunt, we tell them straight away. So for me, I think those two, would be the things that I would want to say. Probably listen from the others too, if they have.
Okay, maybe just a short follow-up question. So you see the value of coming to your country, training you there is bigger than the value of bringing people over to Europe, training them in Europe, and then sending them back to their country, right? That's what I understood.
Yeah. So in the case of hydrocephalus, yes, the reverse fellowship really, I think it's more valuable if you want to look at it from the point of view of the work that you are going to do. Because that the other thing is that when we come to Europe, we come to a very high standard level where we are taught very high stuff, and sometimes it's very difficult to assimilate that and practicalize that in a low income. But when you come over to us, you see the challenges. Yes, you see these are the challenges that we have, and you are able to teach us in our challenges. And when you go, it is very easy for us to continue that, as opposed to when we come to you and the whole place is just impeccable, as the French would say. So it's different there. So I think with regards to hydrocephalus, I would give the reverse fellowship a higher grade than somebody coming to Europe to learn.
Mm-hmm.
Okay. I noted that, Martina, you said that it's also always you learn things, and I also always think it's a learning experience, because when we come down, we can see that you can do things in another ways that we are used to, and that is, I think, very useful for us as well. So I think it's a bilateral learning.
Yeah, and I completely agree with John, because the presentation, not only the circumstances under which you sometimes have to work, but also the presentation of the patients is so different from what you can see they come to us. So learning there on the spot is definitely the better thing.
Yeah, because we see the natural history we never see in Europe, for instance, as your patient there with a huge head. I think we missed one question from Imelda Fonke from Grenada. She said good morning. So this is morning in West Indies, and she encountered child with hydrocephalus in Grenada, and obviously you can't treat them there. So that's my question to Michael Dewan then. Because West Indies is close to US, what could you do with a kid like that in Grenada?
Maybe I don't know the details of the
No, of course not.
But just I mean, you could probably copy and paste that, and it would be relevant, every hour of every day. I mean, that's the whole problem, right? I mean, how to answer that. I suppose probably would be helpful to understand what capacity exists in Grenada. I don't know who is available or what kind of public resources are available, but I suppose it would start by understanding and going first to the individual or the individuals who are tasked with treating neurosurgical patients, starting there, and then understanding what public resources are not available. But I don't think the right answer is, say putting a patient on a plane and flying them to some place. I think that's not a reasonable, sustainable solution.
Thank you. That's a lot of these small countries with neurosurgeons. We have them in the world, and it's a very special problem. I know Elian dos Santos is in our committee, and she's the only neurosurgeon in Curacao. That's another West Indian, and it's very special to be the only one on an island. And sometimes she got patients from other islands as well. So yeah. Okay, Jehuda, next.
So the next question would be, I guess, also to John and to Tejan. Which parameters in your case do you use to decide if to perform a shunt or a ETV? Do you have parameters, or is it just you go for ETV first and then shunt, or how do you do it? Maybe Tejan, if you want to answer that.
All right, I would answer that based on the few experience we have in Sierra Leone. So we don't have any established protocol prior to the cure protocols. It has been mostly resource dependent, and most of the times before the presence of SANC in Sierra Leone, it has been only shunts, ventricular peritoneal shunts, not even the other forms of shunts, not the ventricular biliary shunts, or whatever the case is, based on the current situation of the patient. But we don't have any established protocol on that. It's shunts. When there is infection, we remove the shunt, wait for at least a period of 21 days. If things get better, then at a particular time, they place in another shunt.
John, do you maybe have since you've been starting doing ETV CPC, is it something that, how do you decide?
Yes, so since we started with the NeuroKids, usually the decision is a joint one. So once we have the cases, we will sit down locally to just decide and say, okay, well, we think this one we want to go on for ETV, especially obstructive hydrocephalus. We are classical. We think we want to go in for that. But that is then sent also to the NeuroKids domain, and we would also wait for them to hear. Somebody will come up to say, okay, well, he thinks it's this, he thinks it's that. And I would say 99%, we would go with that. There are always sometimes that it's a gray area, and we just look at what we think we would want to do. And for now, because of also the infection rates with shunts and so many things, anytime we have a very slight chance of thinking that somebody could improve a little bit from an ETV, we want to first start with ETV. Yeah.
A follow-up question to that, because the follow-up of the patients is very often very difficult. I was impressed by Eritrea example that we had such a good long-term follow-up. How do you deal with that, John, and also Tejan? Because I know it's a big problem to know how good the treatment is. Yeah.
Yes, thank you so much, Prof. Magnus. So we do lose patients to follow up, but it's not really very much because of the size of the country. So the country is small. From one end to where we are, I mean, it will take you like, let's say 6 hours, for instance, and most of the times, the patients that we have, we don't lose them to follow up. Yeah, so if I would say probably we would lose about, say 20% or less, but the rest we do. And we also established a clinic. And in fact, currently we are trying to get that, like a special clinic only for, hydrocephalus and spina bifida. Yes, and the foundation that we have, which is the Lamin-Keita's Hope, that's a Gambian living in the US whose child had spina bifida and later on hydrocephalus. And so she came back and formed this nonprofit and also trying to help the people. So that also helps, to get the parents together and that, but it's not perfect. We still lose some.
Okay, that's impressive.
I also have a follow-up question. I wanted to ask Michael and Martina, maybe also you, Magnus, because for sure in Europe and in the States, the indication for ETV and CPC is mostly for obstructive hydrocephalus. In most infectious cases, we might not be doing it. Maybe you do it more, Michael. I don't know, but is it different? Do you think different when you treat the patients there? Like you say, okay, the shunt might cause more problems, so I won't look at the ETV success score, etc. I will just go for the ETV when I think there's even a 50-60% chance it works, and do the shunt only then when it's needed. Is from your perspective, when you assist these surgeons there? Do you teach them a little bit different than we teach our residents, for ETV and shunt?
It's completely different, because you really have to think what is achievable. And when you see the pathologies, at least my experience in Eritrea is that I know that ETV alone will not help in this terrible macrocephaly cases, specifically because we do not have the resources to wait and watch with an ETV plus an EVD and then taper it down and relieve them from their burden. But we quite often combine ETV plus shunt, and we inspect the ventricular situation, and sometimes also before CPC. But in most of these cases, there are hardly any chord plexus structures left in these high-end cases. So it is always you cannot say, yeah, we do it like this or like this. Of course, if you have a very good case which comes early, which is not infected, has been infected recently, we perform ETV alone. These are the good cases, the very good cases. We pick up 1 or 2 each time, but most of the cases are the huge macrocephalic patients, which would not take profit from it, from my perspective.
What is your experience, Michael?
Yeah, I would agree that the counseling and decision making is certainly different between the two settings. For example, in my practice here, most of the patients who I'm having a discussion about ETV, CPC, or shunt, they come to my hospital or clinic having already read about both, and sometimes they have opinions about what it is that they want. Obviously, that's not the case in most other places. We use less obstructive or non-obstructive hydrocephalus in our decision model, both here where I practice as well as where we advise, and we focus more on the age of the patient and their ventricle caliber. We know that including those, as well as whether they've had hydrocephalus intervention before, like a shunt, those are really the 3 factors that matter most, even more so than etiology, myelomeningocele, post-infectious, et cetera. The etiology washes out when you incorporate age and ventricle caliber as measured by the FOHR. And so we use those factors most. But generally, as we are advising other surgeons, we've been there, and so we kind of generally have an idea of what their environment is like. And so we're probably more likely to have a lower threshold to go with the ETV CPC in places where we know that their shunt infection rate is, 40 or sometimes 50+%. We might go for a 40% ETV success rate, knowing that that may not be a bad option if they've got a shot.
Yeah, I think that's an important point. Yeah.
Yeah.
Sorry, can I ask Mike, please?
Yeah.
Sure.
All right, thank you. Maybe I can start my question by at least saying a little bit of my experience here in Venezuela. It's also a third world nation, probably slightly better off than where I come from. Most of the times here also we've had the majority of the cases here are congenital, but we've also had post-infectious hydrocephalus, and most of the times they are complicated with septations. They present with cavitations, in which we try to do the endoscopic ventriculostomy, and then we end up doing fenestrations of those septa, those cavitations. But then almost always that fails. After the fenestrations of the septations, we'll probably end up putting in a VP shunt. Is there anything different in the management of those cases that present with ventricular septations compared to just a simple case in which you didn't have any septations and you just did the third ventricular ventriculostomy? And what outcomes or how would you manage that if you've ever had cases like such?
Yeah, it definitely is different, and it makes it more complex. But also keep in mind that the original most high level data on ETV CPC was in a post-infectious hydrocephalus population, the randomized trial. So the majority of those patients did not just have straightforward, aqueductal stenosis, for example. And so, but it is the case that if it's simply just a fenestration of the supratentorial space or above the third ventricle, that's not going to be an effective measure if there's an obstruction beyond that from a septation or otherwise. And so it has to be included with some communication with the subarachnoid space. So like performing an ETV, for example. So it's not, if one is just fenestrating a cyst, unless it's fenestrating it into the ventricular network that is otherwise communicating with the fourth ventricular outlet, it's not going to work. So it has to be fenestration plus an ETV. And yeah, I mean, they in super young patients, 1-month-olds, their likelihood of success is low, but that's true of other etiologies as well. But I think the key is it's not just fenestration. It has to be an effort to get the endoscope into the subarachnoid space in some way, shape, or form. Yeah.
All right, thank you.
I can just comment from how they do in Malawi, in Blantyre. Malawi is 20 million inhabitants, and had just one research surgical center for a long time, and a very high pressure of a lot of patients. They do ETV and CPC on all of them firsthand, and then they see what happens. And I think around 50% of them get shunt later on, but they start always on all patients with ETV and CPC. And it's a kind of working algorithm, so to say, but it's from necessity.
Yeah, it makes sense also, yeah.
Yeah.
They spare 50% chance, so they look at the other way around. Yeah.
Okay, so many questions. We were asked if it's access to the presentation. Yes, they are accessible on the EANS website afterwards. And then there is Maria Machado from Portugal that asked me we should go into Sao Tome and Principe, and that's a very small island nation in the West Africa, and they wonder how can they get shunts and an endoscope beside occasional donations. And I think to make it sustainable, that's the big question always. Anyone who wants to comment on that, because the sustainability is always an issue. As John said, you get some things, special consumables, but how can you keep it going? And that has to do with the financial system of the healthcare system and so forth, of course. John, do you want to comment on that? You have been in this situation many times.
Yeah, so I think that's a very, important question, and that has always been also our preoccupation. How do we sustain what we have?
Yeah.
Most of us in the low and middle income countries, the cost so the Gambia, for instance, the cost for surgical care or medical care is next to nothing. And as a result, you don't also have enough that comes from the government. So that's it. So, but I think probably one of the things we can do when we have these instruments and like, for instance, the NeuroKids get you a whole complete set. It's about how many cases that you do. And assuming in the future you need to have another one, is to be able to make that case to the government. Sometimes some people succeed in that. They're able to, present and say, well, look, we are preventing so many people from going to get treatment abroad, which will cost the government a lot of money. But this machine needs A, B, C, D, and E. But you may succeed in that. You may not also succeed in that. I've never succeeded in that. So it's a big question, and I don't really know what the answer to that question really is.
Mm-hmm. Any other comments from Michael? You have also been involved in this kind of discussions many times, I guess.
Yes, it's of course it's an impossible question, right? If it was an easy answer, it would already be done. But no, I mean, running an organization that takes private donor dollars, that's not sustainable, right? That's not, this is, we're band-aiding. I think that the answer probably, of course, every country, my own, perhaps most obviously, there's corruption and money's being used for things that shouldn't be used for. So I think that one of the answers is going to be, and it's already happening in some places that where there are national surgical plans that are being built and created. And by the way, those surgical plans which go to a Ministry of Health from a Ministry of Finance, those are being crafted based upon data that people in this audience have put together to argue that, listen, this is a problem. Head injuries are a problem. Hydrocephalus is a big problem, bigger than, more people dying, from head injuries in some places than HIV and tuberculosis, where that wasn't true 20 years ago. And so it's crafting an argument that this is really important. This should be prioritized by the government, and public dollars, public pesos, public ruble, whatever currency it is, should be devoted to this, where it's not being devoted to it right now, or it's being squandered in nefarious ways. And so I think it's probably going to take that level of commitment from the federal side to trickle down to really make the type of impact that's going to need to happen, other than, little things like NeuroKids that just kind of, help, but it's kind of like, pissing in the ocean.
Yeah. I think one problem in many poor countries is that the people with the money and the influence, they don't get the treatment in their own country. So they leave for Paris or US or wherever when they want the treatment. So they never see it. It was a little bit different during COVID times, and some people realized that the national healthcare is important. But the people with influence, the people with money, they get it somewhere else. And I think it's a problem, a systematic problem. Martina, in Eritrea, is it different?
Yeah, Eritrea is really a country where you cannot talk about in black and white. Of course, all the world is telling it's belonging to the 3 worst countries in the world. But if you really look into this country, which is deeply socialistic, and they have a real astonishing healthcare system, although they are so poor. But a little bit what we know from old Cuba, they provide free access to healthcare, and the people working there, they're giving everything they can give. And what Eritrea, for example, is providing is a screening booklet for kids. In Germany, we say the yellow booklet, and they have yellow booklets, all the kids. And the diagnoses are well set. Also the hydrocephalus, the problem are the resources, which are not there. And the few money the country is spending, or is able to spend for healthcare and education, which is very high up on the list, it is really well distributed. And I think it is quite extraordinary for an African country like Eritrea that there is free access for everyone from one day to the other, if needed, to CT or MRI. And you have to know that the referral hospital of Asmara, which is covering a population of 2 million people, has a yearly budget for everything, for all the people working there, for maintenance, for technology, medication, blood bank, of roughly $1 million. This is incredible. I think no one of us has an idea how this can work, because anything they have to purchase on the global market, because they are not producing cheap things on their own. So I think even if the governments try to do everything, there is not enough to distribute. And at least in Eritrea, I don't feel that there are some people richer than the others, only the expats. And this country is mainly supported by expat money, because they do not have their own industry. So there's nothing like corruption. Of course, the one who has a family abroad with some money can and gets permission for medical treatment outside of the country. But these problems are political, but different dimensions, I would say.
Fantastic, amazing stories. I think our time is up, isn't it, Jehuda?
Yeah, unfortunately.
It's been a great discussion, and there are questions still there, but I hope these discussions can continue.
We need to set up another webinar for the next questions.
Exactly.
Yeah. So we want to thank all the speakers. It's been also fascinating, I think, to everybody which was listening from both perspectives. And thank you, Magnus, also.
Yeah, thank you, Jehuda,
for sharing this. And I just was asked to mention that next week in Oslo we are going to have a hydrocephalus session, a joint meeting of the hydrocephalus and pediatric of the EANS. Radek is organizing it, so whoever is not on board yet, please join. And with that note, thank you very much, everybody.
Yeah, thank you also.
Thank you. Thank you all.
See you all. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.